from that you view that the Yale New Haven health system, with all of its integration, is somehow immune from the application of the CON factors that talk about primary service areas of individual institutions such as such as Greenwich Hospital?
The answer to that is clearly no. I'm in tremendous respect for the legislator, and that is why I'm physically here in the room, and willing to take any questions. We're not immune. We are part of the solution for healthcare in Connecticut.
Okay, I just wanted to make sure, because I didn't want to misunderstand you, that somehow you thought because of what you described as the signature and the integration, that somehow made your organization, including Greenwich Hospital, somehow exempt from some aspect of CON.
Objection. This question's been asked and answered.
I'm going to sustain.
Okay, thank you. Now, you did in your testimony quote from an American Heart Association document, I believe. Am I correct?
Yes, on several occasions I've quoted from the American Heart Association documents. I don't know, you'll have to be specific about which one and whether it's in my written testimony or in what I provided this afternoon.
Okay. The document that I'm referring to is a document that, well, in your testimony, the quote, which is bolded on the first page of your pre-filed testimony, states that, and it's giving reason, that you're explaining your reasons in support of the application. It says the second reason was PCI and this is quote, PCI without on-site surgery is a reasonable consideration for providing local care to patients and families who do not want to travel significant distances or who have certain preferred local physicians, close quote, period. Did I read that correctly?
That is correct. I agree with that statement.
Okay. Now, you did not quote other portions of that same document, and I'm referring to page 2 of the document, where under the heading, and this is the American Heart Association and American Stroke Association, which you had referenced before as being absent from one of the other documents I was quoting from. They are under a heading that says recommended policy guidance for states wanting to address the issue of PCI without surgical backup through regulation or legislation. And in that statement, it says, and if you have it in front of you, you please tell me if I'm reading this correctly.
Please go ahead, sir.
I'm reading at the bottom where it introduces the bullet points. This policy guidance applies to hospitals conducting both primary PCI and elective PCI. And when you go to the third bullet, it says, have an annual institutional volume of at least 200 to 400 cases. Did I read that correctly?
I am looking at the same document that you are, yes. And you read it correctly. This is the document from 2011. Please confirm.
2012.
Understood.
Thank you.
And I apologize, doctor. I know you have a very impressive CV, and without me going through it now, what is your specialty?
Well, as you know, I am the chief of cardiovascular medicine at Yale. My clinical subspecialty has been focused on coronary disease and heart failure, as well as cardiovascular imaging. That's what that's what I have done clinically in my career.
Now, you are, I appreciate that. Does that mean in your day-to-day work you do or do not do elective PCIs?
That absolutely. I was trained as a cardiologist. During my training, I was trained to do cardiac angiography and intervention. But in my day-to-day activities as a chief of cardiovascular medicine, I do not practice, nor have I ever practiced as an interventional cardiologist.
And lastly, you don't dispute that Stanford Hospital and Greenwich Hospital are in the same local community, correct?
You know, I do want to comment on that. I think the same local community is not there is no right answer to that. I guess that's what the answer I would ask patients. From my perspective, a geographic mile distance, yes, they are very close by from each other. Whether a individual who lives in Stanford would identify Greenwich as their community, or whether an individual who lives in Greenwich would identify Stanford as part of their community, that I leave to the community residents who make those choices. I don't live in either community, so I can't speak to that question. I think that is a question that can only be answered by the patients.
And what about the Office of Health Strategy?
I again have tremendous respect for the legislation, and if that's how they define it, I have to say I don't have a working knowledge of the legislation, so I will leave that to the individuals from OHS to define.
I have no further questions for this witness.
Dr. Velasquez.
And I have just a few questions for Ms. LaRusso.
Okay.
Hello, Ms. LaRusso.
Hi, how are you?
I'm doing okay, thank you for asking. So, Ms. LaRusso, you submitted pre-filed testimony in this matter in support of the application. And as I understand it, you are the Vice President and Executive Director for the Heart and Vascular Center at Yale New Haven Health, correct?
That's correct.
I take it from your pre-filed testimony, Ms. LaRusso, that you are familiar with the statewide healthcare facilities and services plan.
Yes,
And in fact, you quoted it in part, section 1.4, correct?
if you show me what page, I will review it.
Sure. In your last paragraph, you quoted,
Yep,
you said, this proposal
yep,
is consistent with the guiding principles in section 1.4 of the statewide healthcare facility and services plan to ensure access to quality health care, facilitate access to preventive and medically necessary care, maintain and improve the quality of healthcare services offered to the state's residents, promoting planning that helps to contain the cost of delivering healthcare healthcare services to its residents, and promotes planning that will achieve the appropriate allocation of healthcare resources in the state. Am I correct?
Yes.
Now, that was quoted from section 1.4, guiding principles. In that lengthy description of your quote, you omitted the introduction, or at least portion of the introduction, if I'm correct, of 1.4 guiding principles that says the goal of OCA's planning and regulation activities is to improve the health of Connecticut residents, increase the accessibility, continuity, and quality of healthcare services, and prevent unnecessary duplication of health resources. You see that?
I don't have it in front of me, but I'm going to trust what you're telling me.
Okay. Did you purposely not include those words? In other words, no? Okay. So that was inadvertent?
There are several statements that I felt were important to this document, this being one of them, but there was no specific intent.
Well, are you aware in your role that one of the CON factors that the legislature has set forth as important determinations is whether the proposed service will create unnecessary duplication of health services?
I understand what you're saying, but I do not think this is unnecessarily duplicating services.
Okay, so you disagree with it?
I don't think that what we're requesting is a duplication of unnecessary services.
And is that why you omitted it?
I didn't intentionally omit it, but.
Okay. How about the other portion of the statewide healthcare plan that pertains particularly to this very service, the PCI elective service in the statewide healthcare plan? Did you purposely omit that?
Objection. We don't know what he's referencing.
I can only a little.
Hold
on, I didn't even hear the objection. I just want to make sure I hear what was the objection, because I didn't hear it.
He's asking the witness, Ms. Mitchell, if she intentionally deleted or omitted something, and we don't know what he's referencing. He has not told us what the statement is that he is.
I'll be very clear.
Okay.
Thank you. Thank you.
Thank you both.
You chose to quote the preamble with an inadvertent omission of one of the wordings related to the factors in the statute. My question is now, did you, when you decided what you were going to include in your in your reference to your pre-file testimony in relation to the healthcare plan, did you make a decision to ignore or not include on purpose the cardiac services section of the health plan? And in particular, the statement that says Connecticut hospitals seeking authorization to initiate an elective PCI program without on-site cardiac surgery capabilities will be required to meet the conditions required in the ACCF/AHA/SCAI practice guideline and to demonstrate clear public need for the program. The guideline states that it is only appropriate to consider initiation of a PCI program without on-site cardiac surgical backup.
Attorney Mitchell, I'm
Can
gonna
I
have to
finish?
object.
May I please
Hold on one
finish
second.
this?
Let him finish, and then I'll let you make your objection. Go ahead, Attorney Monahan.
This guideline states that it is only appropriate to consider initiation of a PCI program without on-site cardiac surgical backup if this program will clearly fill a void in the healthcare needs of the community. Further, the guideline notes that competition with another PCI program in the same geographic area, particularly an established program with surgical backup, may not be in the best interest of the community. My question is, did you purposely omit that from your pre-filed testimony?
All right, hold on one sec. Before you even answer that, I'm going to turn to you, Attorney McKinnon. What's your objection?
I object the accusation that we are somehow intentionally misleading the agency is inappropriate. We've at this point agreed that those guidelines and the state health plan are part of the record, and it's up to OHS to make a decision based on the evidence in the record. And I don't quite frankly see the relevance of accusing our leadership of making an intentional omission to mislead the agency.
All right. I do hear your objection, Attorney Monahan, before you even respond. I'm just going to go ahead and just ask the witness, did you intentionally omit anything from the statewide healthcare facilities and services plan?
No, nothing was intentional.
Okay. Attorney Monahan, you can continue with the remainder of your questions.
I think that answers my question. So thank you. I don't think I need to pursue that. I have no other questions. And I believe there were no other witnesses. So intervener has completed its questions.
All right. So thank you, Attorney Monahan. I'm going to go ahead and thank Ms. LaRusso as well for her testimony. Is there anything else that you'd like to present, Attorney Monahan, before we go to break? Because we need to register anybody who's going to be doing public speaking, and also we need to convene, OHS needs to convene to discuss our questions. Is there anything else new or different that you wanted to present?
No.
Okay, and then also attorneys for the applicant, anything new or different before we go off the record for about an hour? I can't even see what time it is. Goodness. For about 15 minutes.
3:10.
Thank you.
Nothing further from the applicant.
All right, so we are going to go off the record for the purpose of registering anybody from the public that may want to speak, and then also for the purpose of discussing OHS's questions. We'll see you back here at 4 o'clock. Sound okay?
Thank you.
Thanks, everybody. All right, just
Can I
make sure.
ask one question?
Yep.
Are the questions that you may ask to potentially each of the witnesses?
So I do think so. If people could stick around or make themselves available, I think so.
Okay, thank you.
Yeah, and just when you walk out of the room, just make sure you mute. She already muted herself. Make sure you mute everything before you exit. Thanks. Hi, we're going to get started in about 7 minutes. This is Michaela Mitchell. I'm from the Office of Health Strategy. If there are any members of the public who have not signed up to speak, I'm going to ask that you privately message Leslie Greer with your name. And then after you've done that, just make sure that you mute your device. We're going to go back on the record in about 6 minutes.
Hello, Leslie.
Yes.
Oh, hi, this is Dave Van Hoesen. And I wanted to register to make public comment.
Okay. So your name is David Van Houston?
Yes, Hoesen.
Okay. All right. I'll add you to the list.
Thank you.
All right. And she'll call your name when it's your time to speak. Okay. You have 3 minutes.
Okay.
Leslie, excuse me.
I'm sorry.
Okay, thank you.
You're welcome.
Leslie, this is Robert Berkeley. I'd like to register as well, please.
Okay. Yes, I have your name. Gerald Topolin provided it to us. So.
Okay, thank you kindly.
Leslie, I just sent you a message. This is Roland Morris.
Okay. Yes, I have you down, Mr. Morris.
Thank you.
Okay. So when she calls your name, you will have 3 minutes to speak. Okay.
Thank you.
You're welcome.
Hi, Leslie.
Yes.
Hi, this is Debbie, the court reporter. Actually, I was just wondering if you could tell me the attorneys, McKinnon and Ashmead, what law firm are they from?
I don't know.
Okay,
Hold on.
because I didn't get that information.
Yeah, they're Yale employees. They work for Yale. They work for the applicant.
Okay, so they're Yale attorneys? Okay, and then Attorney Monahan is?
He is, you know what? I'm going to private message you that because I can't remember the law firm.
Okay, because I just need to put some,
I know it.
identifying information.
This is Brian. It's PPP and C, Parrott, Porto, Parisi, and Caldwell.
Oh, okay. Thank you so much.
Yep.
We're going to go back on the record in about 3 minutes. We'll be back on the record in 3 minutes. Hi, everyone. We're going to go back on the record for the public portion first of the hearing, and then the Health Systems Planning Unit will ask questions. I just want to make sure that the applicants and the intervener are here. Everybody all set?
Yes, from intervener.
Perfect. I guess we're waiting on the.
She's looking for us to say we're
Oh,
here.
we're here from the
Okay.
applicant.
Thank you.
Thanks for seeing that.
All right, so far we have been notified of 3 people that want to speak. I just want to make a brief announcement about that. I'm just going to ask all participants, to the extent possible, should enable the use of video cameras when commenting during the proceedings. Anyone who is not commenting should mute their electronic devices, and then also mute any telephones, televisions, or other devices that are in the vicinity that are not being used to access the hearing, so that we can make sure that we hear you nice and clear. We will call the names of those who have signed up to speak in the order in which they registered. If we miss anyone, please just make sure that you utilize the raise hand function to let us know, and we will get to you as soon as we can. Before giving your comments, we're now transcribing not only testimony, we're transcribing public comments. Before giving your comments, please state and spell your name for the purpose of accurate transcription. We're going to limit speaking time to 3 minutes. Don't be dismayed if we stop you at the conclusion of your time. We just want to make sure we give everybody the opportunity to speak, and we want to make sure that we are fair to everyone. So we don't want to give some people more time than others. We just want to make sure that we keep everything uniform. We strongly encourage you, if you'd like to submit any further written comments to the Office of Health Strategy by email or mail, no later than October 7 of 2020. Our email address is CON, like certificate of need, CON comment, all one word, .gov. Did I get that right, Leslie? Just want to make sure I got that. CON comment.gov. Oh.
Yes, but I mean, we will still get that email address, but we're no longer using that. So it's either that one or ohs@ct.gov.
Okay, thank you. ohs@ct.gov. And then our mailing address is P.O. Box 340308, 450 Capitol Avenue, Hartford, Connecticut, 06134-0308. If you didn't get all of that, it's okay. We're going to post the hearing video in a couple of days. So if you need to catch that, then you can go ahead and fast forward to this part right immediately after the break, and you'll be able to capture the address. Or you can also email us to ask for the address or call us. Our contact information is also on the website, and I just want to thank you in advance for taking time to be here and for your cooperation. We're now ready to hear statements from the public, and the first person that I have that I want to unmute themselves is Mr. Roland Morris.
Good afternoon. My name is Roland Morris, R-O-L-A-N-D, Morris, M-O-R-R-I-S, Jr. I live in Greenwich, Connecticut. Almost 4 years ago, I had a serious cardiac event. I went into cardiac arrest outside of the hospital. Fortunately, I was with people that knew CPR, and there was an AED machine there. And Greenwich Emergency Services was there within about 8 minutes. I then was taken to Greenwich Hospital. I, of course, don't know any of this or remember it. And I did take 40 minutes to stabilize me, but waiting for me at the hospital was Dr. House. He literally saved my life. He was inside my heart within minutes, I'm told, and unclogged a fully blocked I don't know the technical term for it, but I think they refer to it as the widowmaker. I was then put in a coma for a couple of days. My first memory was being put into an ambulance and transferred up to New Haven for a follow-up procedure. This ended up being fairly stressful on me because I was barely understanding what had happened to me. It took me a long time to get any memory. And it was quite stressful on my family. And it seemed to me at the time that the most dangerous thing that had happened was taken care of fantastically at Greenwich Hospital. And it seemed odd that we had to transfer up to New Haven. My care there was fabulous. The doctors were great. They put in one more stint. I had an unfortunate experience the night of, but that was just an unlucky room, I guess. But I think Greenwich was just an amazing result, and life moves along quickly for all of us. And in the last 3 years, fortunately, I've been there for 2 weddings, 2 grandchildren, and a 3rd grandchild on the way. And I have all of that to thank Dr. House and Greenwich Hospital. So thank you.
Thank you, Mr. Morris. I appreciate your comment. We'll move on to Mr. Robert Berkeley.
Yes, good afternoon. Thank you for the opportunity to participate. As you said, my name is Robert Berkeley. That's R-O-B-E-R-T B-E-R-K-L-E-Y. I'm a resident of Greenwich, Connecticut, and I am currently the chair of the Board of Trustees of Greenwich Hospital. I would like to offer my support for the proposed addition of PCI services to the existing array of cardiac services currently offered at Greenwich Hospital. This proposal represents a unique opportunity to improve access to high-quality care locally, a concept which is of utmost importance in the post-COVID-19 healthcare environment. With safety a top priority, an elective PCI program at Greenwich Hospital would adhere to the monitoring and standards set forth by the Yale New Haven Heart and Vascular Center. Implementation of elective PCI at Greenwich Hospital would enhance the overall quality of the cardiology program and more fully utilize the expertise of the local cardiac specialists. With these physicians able to perform both angiogram and elective PCI, familiar providers will continuously monitor patients prior to, during, and after the procedure, improving the continuity of patient care. It's my understanding that there is some concern, perhaps, that if this was expanded at Greenwich Hospital, it could somehow adversely impact other practices in the area. From my perspective, it's quite to the contrary. This type of procedure is a serious procedure that people look for healthcare outside of the immediate area. They look to major medical centers, teaching hospitals. And as a result of that, they are drawn to places such as New Haven or New York City. In the event that we found ourselves in a position to offer this type of care in Greenwich, we could then be offering world-class care when it comes to this type of procedure, not requiring people to travel more than an hour in order to get this level of care by this level of healthcare provider. As both the chair of Greenwich Hospital and, more importantly, a lifelong resident of Greenwich, Connecticut, I ask that you review these considerations from a perspective of enhancing services to our community, or our several communities that we serve, while honoring the importance of choice of healthcare. Thank you for your consideration of Greenwich Hospital's Certificate of Need application to add elective PCI services to the continuum of cardiac services already provided by the hospital. I strongly encourage you to approve this application. Thank you.
Thank you, Mr. Berkeley. Oh, great. And then we are going to move on to Mr. Is it Van Hosen? Is that how you say it? I don't want to make a mistake there. Take your time. It's okay.
Unmute. Can you hear me now?
I can hear you.
Terrific. Yes. So I just wanted to share my experiences, similar to Mr. Rowland's experiences at Greenwich Hospital and then at Yale New Haven. In 2015, I had a cardiac arrest on a paddle court at Millbrook in Greenwich. They kept me alive through use of a pump on my chest, a mechanical pump. GEMS was great. I went into the hospital. I don't remember any of this, but apparently I was stented with 2 stents and cleared blockages, with an emergency at Greenwich Hospital. And my family was there, and they were all rejoicing. They had me in a induced coma, I guess, for a couple of days, and they kind of woke me up just enough to make sure I was okay, to then put me back under and say, okay, well, there's another minor one. We need to send him up to Yale New Haven to get fixed. And so I don't remember any of that, but I do remember waking up in Yale New Haven at 2 a.m, not knowing where I was or why I was there, or what was going on, and kind of some strangers in the room. And I was totally taken back by it. I was very upset. And it may have to do with the medications, I don't know. But they found my family, who was busy checking into a hotel at 2 a.m. And they came and kind of settled me down, explained what had happened and so forth. Then they, once things got settled, they explained I needed to have another stent put in, not a major one, but a stent put in. And that was fine, and that was straightforward. Doctors I'd never met before, doctors I'd never seen then, nor seen since, frankly, did it. But it all worked out fine, and I went home. And I'm very thankful to be alive. But I really feel that it was due to the work at Greenwich Hospital and Dr. Howes and his crew. But I'd then like to fast forward 5 years, which was this past summer. Through COVID, I was feeling some discomfort, wasn't able to get into to see the doctor and so forth. Then I was able to see, finally I got in and was through an echocardiogram. Then I'm like, oh, time for an angiogram, go into the hospital. I went into the hospital and they take a look and they're like, oh, yeah, there's an issue here. One of the old stents is clogging up and, well, we're not allowed to do it right here, right now. And I'm like, you can't do it? It's not an emergency? Well, it doesn't really qualify as an emergency. It's like, okay. So then I get put into an ambulance, shipped up to Yale New Haven.
Hold on one moment, Mr. Van Hosen. Am I the only person that's experiencing difficulty hearing? Okay.
I can hear him clearly.
Okay. Try one more time. I think it was just me.
Well, so I won't start from the beginning then?
No, I heard you say that you were transported in an ambulance, and then that's when it started. Okay.
Well, so then they started in an ambulance. They transferred me up to by ambulance to Yale New Haven again. And I was put into a room with other sick people with different issues. And it's kind of in the height of COVID. And I feel like, oh boy, I'm getting exposed again, all over again. And I'm in a place I don't know anybody, and nobody can visit me. I can't visit anybody. I'm far from home. Anyways, so the next day I go down and eventually they say it's time, for me to meet, to get my stent done again. And it's with doctors I've never met before. I've never seen since. Obviously, I'm here, I'm happy, and I love being alive, but it was a little distressing for sure. And then I get to go home. I really feel that, and given the risk rewards and that sort of thing, that had I been able to have that done in Greenwich at the time, I wouldn't have had to go through medication again. I wouldn't have had to been exposed to different, germs and potential viruses, that sort of thing. That it would have been much better to be at Greenwich. And that's what I have to share. And to be with your own doctors is a value to that, and there's a value to having your family around you, and so forth. And I forgot to spell my name for you at the beginning. So should I do that now?
Yeah, if you wouldn't mind, I think it's actually underneath your name. Let me just check.
Yeah,
Debbie, are you all set with his name, or does he need to spell it out?
I'm all set. Thank you.
No worries. Okay, so the core reporter has it, and we're all set. Thank you so much for your comment. I'm going to ask, is there anybody else from the public that wants to make a comment? Just unmute yourself and let me know. All right, so I don't think I hear any comments for now, but we'll still leave it open for people to make comments until we're actually going to stay until about 6 o'clock. But in the interim, we will go to the Health Systems Planning Unit's questions for the applicants and for the intervener. And pardon me, I'm just pulling them up. I actually am going to start, but before I go to the questions that Brian, Hannah, and I discussed, I just want to ask a question that, it just kind of came to me after hearing Mr. Van Hosen's comment. And I guess that would be with regard to the precautions that are being taken to protect patients from exposure to COVID-19, and whether or not those are implemented at every hospital that's affiliated with Yale New Haven Health Services Corporation. If there's anybody that can answer that on the applicant side.
I could speak to that. This is Francine LaRusso. Yes, we do adhere to COVID requirements and restrictions at all of the health system hospital. We have the same standards and practices across all the delivery network.
Can you talk a little bit about what those standards are when somebody presents maybe in an emergency situation, or for example, if they need, emergency, it would be PCI. If they need PCI, what does that look like? How are they separated from people that have other situations going on?
Okay, Dr. House wants to, he's interfering in my response. I'll let him go ahead.
In the COVID era, we try to do pre-procedural testing, screening for COVID infection. So for example, Mr. Van Hosen's second experience when he was seen in the office was having increasing symptoms, had an abnormal non-invasive image. We had the luxury of a couple days. We scheduled him for a COVID test. The next day when it was negative, he had his angiogram. And then we had to get him up to New Haven, kind of still on that same negative angiogram. We have about a 48-hour window to kind of think that they still have a negative COVID test. That's very different than like what both of these patient stories would have been in 2020. I believe Greenwich Hospital was the first hospital in this state to do a STEMI intervention on a COVID patient. And I'm sorry to say that patient did not survive. But we had to do it. There was no time or waiting, and we put on our full protective PPE, and we take care of the patients. And fortunately, with that protective behavior, we did not have any staff that got infected from that interaction. All of these unstable patients that come in through the emergency room now, if they get admitted, they will all be tested. But again, the STEMI patients, you don't have the time to wait. So we just always assume that they are COVID positive. We treat them with a mask, and we treat the entire staff with full protective gear. And it does honestly add time and delay, and it's never as easy to take care of these patients in the current environment.
And those precautions are uniform and universal across every Heart Vascular Center site. So it would not be different at Yale New Haven Hospital or Bridgeport Hospital or at L&M.
Thank you. All right, so the next questions are for the purpose of ensuring the accuracy and completeness of the record. Is there anybody in the room on the applicant's side that can name all the towns that comprise Greenwich Hospital's primary service area?
Okay, this is Norm Roth speaking. In the file, page 13 is the service area towns, and the primary service area of Greenwich Hospital is Greenwich, Portchester, Rye, and Stanford.
Thank you. The next question that I have is, are there any other hospitals that are located within the actual physical hospitals located within Greenwich Hospital's PSA that provide either primary or elective PCI?
Well, obviously Stanford is in that, but in the other areas, there is no other hospital at all in those other towns. And the residents of those towns do get the majority of their healthcare services here at Greenwich Hospital. In fact, over 50% of inpatients admitted to Greenwich Hospital reside in Westchester County. So we have a very strong draw in eastern Westchester County to Greenwich Hospital.
It leads into my next question somewhat. And, I think that the application talks about it as well. Are there any, and this is just again for ensuring accuracy for the hearing record, are there any additional hospitals that provide primary and elective PCI services to patients residing within your PSA aside from Stanford? So that's not if the hospitals are located in the PSA, but are there any other hospitals that provide services that you know of to residents within the PSA?
Well, the White Plains Hospital does provide primary and elective PCI, and they may draw patients from eastern Westchester, but then their referral for cardiac surgery and other advanced cardiac services will be to Montefiore in the Bronx.
And the next question that I have, and thank you for that response, it's regarding improvements in quality within the region. So the question has a number of parts to it, and I'll try to make sure that I break it down so that whomever is answering remembers what I'm asking. But this is based upon the projected PCI volume that's in Exhibit E on page 436 of the application. And that in that volume, it basically indicates that Greenwich Hospital is not expected to meet the institutional minimum of the 200 PCI procedure threshold through fiscal year 2020. So we talk a lot about your perspective that the volume is kind of part of a larger picture of what one should look at when you look at quality. It's not the end all be all. But then the question that I have is, how will this proposal improve the quality of healthcare delivery in the region if the minimum volumes required to support better patient outcomes are not met?
I'll give it a try. Again, part of quality metric is patient satisfaction, and I don't think there's any question that both of the patients that testified in this hearing and what the testimony has borne is that patients want to stay locally, and in the COVID era more than ever. So I think there will definitely be patient satisfaction issues. I think Dr. Velasquez argued the point that although the physical site of Greenwich Hospital would not achieve 200 patients, and I actually believe that we would not achieve 200 patients, our HVC system and our HVC protocol achieves much more for the functioning lab, the people in the lab, and therefore the patients that experience an intervention at a hospital like this, which is very different than a small isolated hospital that has no support to it. And then one other point that I think is worth bearing in mind in talking about improving patient outcomes, we're a primary angioplasty program, and we take great pride in how serious we take this job and how good we think we do our job. But at the end of the day, we're doing 40 or 50 interventions a year. And if we got an elective program, we might not achieve 200 procedures a year. But if we get to 150 or 175, that's actually exposing our staff to more local intervention. So we're actually increasing our patient volume directly by offering more services. And that may translate into some improved procedural care. I don't know, but it's not going to hurt us by doing more.
And if I might add to, again, going back to the concept that we've talked about being an integrated health system and the Heart and Vascular Center, we do have a very cohesive performance improvement team. And we are part of, across all of the DNs, the same registry around ACC, NCDR registry, which is really a comparison across our quality metrics. And we actually track our physician performance as well as interventions that we can improve on as a team. And we adjust protocols and interventions based on that. And I think that is something that is a significant offering for the community here at Greenwich that perhaps they would not have.
And Ms. Mitchell, can I add an additional comment if there's time?
Absolutely.
So I would say Dr. Howes probably is underestimating the impact of the care that he provides and the great stories from the individuals who joined us this afternoon. My sense is we can't speak to exactly what the draw will be when we have an elective angioplasty program here. That in fact may be one that could engage, above and beyond the thresholds that are identified as a guidance. But I go back to the specific perspective that we, in terms of quality improvement, I would stipulate that the Greenwich community benefits from the extensive, again, in the thousands of procedures that are performed by the same staff, same faculty, operators, under the same quality metrics, under the same reporting standards, and the sharing of those quality standards and that experience is something that is directly applicable to the residents of the Greenwich service area, and that in many ways outperforms the capacity for that kind of experience for others because of that breadth. So I do think that when you talk about the impact on quality, volume is an important component, and you raise it, and we certainly agree. I don't see any reason why we would not be able to meet that that volume number that is stipulated as a guidance. But what I think we bring beyond that is the fact that all our patients, Mr. Van Huysen, Mr. Morris, all of them have the benefits of being cared for by the staff and faculty who are part of a larger organization and benefit from the combined expertise of that organization. And I think that's very important to highlight.
Thank you. I think you touched on this next question and answered it, but do you expect to ever reach that 200 PCI procedure threshold at the Greenwich facility?
Maybe if I can take the first stab at that. You know, what we know about cardiovascular disease is it is already the #1, cause of morbidity and mortality in the US, and growing as the population ages and increasingly as the population gathers multiple risk factors like diabetes and obesity, which we know is also growing. The Connecticut population of patients who are aged, particularly in the Greenwich region, is also growing. So I don't see any reason why we would not expect, due to population trends that have been published, that the need for a program that could serve more than 200 patients, I suspect that would be met, very quickly, just because of the population expectations we have for not only a nation, but with aging in the population as a whole and in Greenwich County itself.
And this is Norm Roth. I'd just like to add some further information to that. Exhibit J in the table of records, response to hearing issues, we identified that Greenwich Hospital sends approximately 50 patients per year directly from Greenwich Hospital to Yale New Haven for elective PCI services. And we have identified that nearly 150 patients who reside in the primary Greenwich service area travel on their own to Bridgeport Hospital or Yale New Haven for elective PCI services. So I believe it is in the realm of possibilities that in the future, Greenwich Hospital will independently be at that 200 case threshold.
If I were to ask you to just make an educated guess, do you know about when that would be?
No, but we would have. I'm going to just mention that if we were not transferring those patients and we were able to provide those services here, then you would reach that threshold immediately. I think that was part of, the supposition is that right now we know, as we heard from our 2 patients who testified, if they didn't have to go to an alternate facility, they would have gotten their services here.
Was that just Ms. LaRusso?
Yes, that was.
Okay, thank you.
The next question pertains to the guidelines, and it is basically this. Is there anything specifically in the cardiac guidelines that would support the operation of an elective PCI program at Greenwich Hospital if the institutional volumes remain below 200 PCI threshold? So we're looking for specific criteria that we could look at.
Can you just repeat the question?
Sure. So the question is, what specifically in the cardiac guidelines would support the operation of an elective PCI program at Greenwich Hospital if the institutional volumes remain below the 200 PCI threshold? So we're looking for specific criteria that we could use to evaluate.
Yeah. You have. So using the 2014 document, that's an expert consensus document from the 3 governing bodies that are commonly quoted, SCAI, ACC, and AHA. I made the point that this is a consensus expert opinion. It's a guidance. It's not an all end all that be all. They point out in that document that in 2008, we're talking, prehistoric history in the world of PCI. In 2008, 26% of the hospitals in this country that perform PCI perform less than 200 PCIs. Of the 33, approximately 33% of facilities had no on-site surgery, and of those, 65%, so 282 facilities had less than 200 PCIs and didn't have surgical backup. Hundreds of hospitals. Now, obviously, they all have different locations and different stories, but they did not say these programs should close. What they say, and it's a couple pages later in the document, laboratories performing less than 200 cases annually must have stringent systems and process protocols in place with close monitoring of clinical outcomes and additional strategies that promote adequate operator and catheterization laboratory staff experience through collaborative relationships with larger volume facilities. The existence of laboratories performing less than 200 PCIs annually that are not serving isolated or underserved populations should be questioned, and any laboratory that cannot maintain satisfactory outcomes should be closed. So we would argue, or have tried to make that point, that we are already actually an existing PCI program. We're not creating a new service. We're asking for access to a new population of patients for a procedure that we've already been doing for 15 years. And we already have these system and process protocols. We participate in the NCDR. We participated in the Seaport registry when that study was being done that created all this body of literature. And we discuss in a system-wide review of the individual operators and the cath labs operators. As the director of the cath lab, I meet regularly with the cath lab directors of Bridgeport, of Yale, New Haven, and L&M, and we talk about what's working, what's not working, what's new in development. So we're constantly pushing forward with development. And I'm the first to admit, if we're not doing a good job, we shouldn't keep doing it. But I feel quite the contrary. We do an excellent job providing excellent care to our patients that reflects in the patient satisfaction and the fact that patients keep coming back to us. I'm not sure that answered the exact question.
The other comment I would add, it's Eric Velasquez, is that in the document, and I'm referring to the document that's the 2014 update on PCI without on-site surgical backup, published in Circulation, and I'm specifically referring to page 2615, which I believe was mentioned in the record with some questioning. And I'll read, second, PCI without on-site surgery is a reasonable consideration providing local care to patients and families who do not want to travel significant distances or who have certain preferred local physicians. This is an important consideration, but the policy statement emphasized that evolving evidence suggests that such centers should have mechanisms in place to ensure high quality care, which is why I continue to refer to the fact that as an integrated system with Greenwich Hospital and our cath laboratory in Greenwich Hospital, already providing 15 years of primary angioplasty within an integrated system where there are measures in place to ensure high quality care and ongoing review, with a volume of procedures for our institution as a system that approaches over, more than 2,000 a year, that we have those quality metrics and quality measures in place. So I think to your question, it is stated clearly in the guidelines that what we are proposing should be acceptable.
All right, thank you for your response on that. The next question is, explain what a high-risk patient is for PCI and describe the process that Greenwich Hospital would use to determine if a patient is in the high-risk category and thus requires the procedure to be performed at a facility with on-site surgical backup.
Okay, so it's a very
Can you
well
just tell me who's
described.
speaking?
I'm sorry. This is Dr. House.
Okay, thank you.
So there is a document that's really ancient history, and just so I want to, it's a 2006 document about PCI without surgical backup. And so that is before the 2011 document that talked about elective angioplasty, and certainly, you know, before 2012, 2014. But that document, even then, acknowledged that primary angioplasty without surgical backup was happening in the nation, and they characterized two different separate things that need to be conceptualized when looking at a patient and looking at where the appropriate place to do that intervention is. And it's a list, and we've included it in our application, that the two charts are there. One of them is describing patient characteristics. How sick are they? Do they have malignancy? Do they have dementia? You know, there's characteristic things of what the patients have. And then there's a second list about more technical aspects of what the angiogram looks like. What's the coronary circulation like? What's the specifics of that actual patient's coronary disease? And I think, unlike primary angioplasty, where you kind of have to make those decisions in the moment, at the second, you know, Mr. Morris had triple vessel coronary disease, but we had to say, this is the culprit, let's fix it. Do we keep fixing other stuff, or have we kind of bought him time to see if he recovers? That's like all on the fly. And we've been doing that for 15 years. And Dr. Martin testified that clinical decision-making is a big part of what we do, and I agree with him 100%. Clinical decision-making is integrating that clinical patient and their coronary angiogram to decide what's safe, what's appropriate, what's reasonable. But in the elective PCI situation, and obviously some of these patients aren't truly elective, they could be having a heart attack, they could be sick, but you do have the grace of time to stop and actually think about this systematically. And I think this is where Dr. Canby, the cath lab director at LNN, has been so successful, is his patient selection is incredible. And that's a testament of how few complications and emergency events have occurred. And this again goes to the beauty of the health system. When I do an angiogram at Greenwich Hospital, our films immediately download into the electronic medical record. And I can call any one of my partners that I've worked with for the last 25 years and say, hey, can you take a look at this angiogram? What do you think? He could be at home in Woodbridge, or Dr. Canby could be in New London. And as part of that electronic medical record, you can get consultative care and say, you know what? That LAD looks pretty calcified. I think we should hold off. Let's transfer them up to Yale. And we do that all the time. On most of these patients, not the primary angioplasties, because it's clear you got to do something. But on the elective ones, you stop, you pause. You know, if it's totally straightforward, it's a stable patient, it's single vessel disease, it's a clean lesion, most of us are going to move forward pretty promptly. But if it's, you know, two vessel disease and their ejection fraction is 40%, let's stop, let's think about it, let's make sure we don't put the patient in harm's way. And that's very well characterized in the documents. We would utilize those kind of flow chart predictive things of what a high risk patient and or high risk lesion would be. And we have the luxury of consulting our colleagues.
All right, I think you actually answered kind of my next stub question, especially when you talked about being able to consult with your colleagues using the electronic medical record. So the other question, if you could just kind of touch upon it a little more, is what types of safeguards would be implemented to ensure that high-risk patients are properly identified?
Well, you know, it's clinical decision making, and we have very experienced clinicians. We openly encourage communication amongst ourselves. We have not here as an elective, as a primary angioplasty protocol, required a physician to like stop and ask someone what they think. But I might be wrong, but I think when Dr. Camby started his program back in 2012, 2013, he used to show all of his films to another senior operator in the system to just make sure he has a second opinion. And, you know, getting two people together is usually better than twice as good. You know, a lot of thought process goes into that.
But every case, every outcome for every case that's performed, and these are not cases, these are patients. I mean, for every patient that we provide a service to, all that information is summarized and reviewed as part of our Heart and Vascular Center performance and quality improvement process. So it's not different for Greenwich than it is for L&M, than it is for Yale. They're all the same, you know, the same faculty, the same operators. So I would argue that our process is that it's universal review, not only because we enter data into the NCDR registry and the ACC and CAF PCI registries, but because that's part of our process internally that we review all case decisions, particularly if there's an outcome where we can learn something from.
Yeah, Dr. House again, I was talking almost preemptively reviewing it before you've done the intervention. Post-CAF, post-intervention, every procedure done at this hospital is reviewed by me. And we have a quality control board. We review all the cases. Obviously, more of the cases that seem to have some kind of question get more scrutiny. But we review every diagnostic catheterization and every angiogram, PCI. And we would continue to review all of those cases.
Thank you. I'm going to turn it over to my colleague, Hannah Nagy, who's going to ask a few more questions.
Great, thank you. So my first question is, please discuss Greenwich Hospital's emergency transfer plan for PCI patients in need of urgent cardiac surgery.
Okay, I think that's me again. Again, Dr. House. So we've been doing this since 2005. We actually have a very well described flow chart of how to transfer patients emergently. And I believe that was included.
No, we did not include
Okay.
it. No, but we could if necessary.
We could show you that flow chart. And it's actually, it is a little more complicated than one would think, because there are options to sometimes fly a patient by helicopter. There are options for ground transportation. And it turns out that we have a ambulance on site here at Greenwich Hospital always, with the capability to transport a patient with not only a ventilator, but big enough to transport a balloon pump. Ideally, those patients can be transferred with emergency medical services, paramedics, but that is not always available. And so on rare occasions, we've had to transfer patients with either an ICU nurse or a physician going with the patient. And that's a staffing issue, but there's always the opportunity to have the ambulance or the helicopter. It turns out it depends on time of day and the weather on what's going to be the quickest and promptest transportation. Yale New Haven Health System has its own helicopter staff, and that is a highly trained staff very comfortable to use the equipment. So that is a preferred method of transportation, but that, again, depends on weather and those sorts of things. Some patients do transfer by ground transportation. And like I said, we have a flow chart of how we work through that. We not only work obviously with the Yale New Haven Health transport system, we do transport patients to New York City and to Valhalla, and they have their own transportation connections as well. And we know how to interface and integrate with all of those.
So going along those same lines in terms of the different modes of transportation that you have at your disposal, what is the maximum amount of time acceptable for this type of emergency transfer?
So again, it kind of depends on what the clinical scenario is. Most patients that need to transfer emergently don't actually need to go to the operating room that minute. It's usually they need to get to a higher level tertiary care center and can either be stabilized or be reevaluated, but they can go directly to the cath lab. I think a more pressing issue is a patient with an aortic dissection. That has nothing to do with anything that we're talking about here today, but those are patients that do come to Greenwich Hospital currently, and obviously it's a common catastrophic illness, and we have been transferring those patients out emergently for years. And that would be the most pressing thing, to get those patients transferred out within 20 to 30 minutes, and then the transportation times 30 to 40 minutes. Because it takes that long for an operating room to get activated. And in the modern era, and this might be interesting to some people, during the COVID epidemic, with all the respiratory failure that was involved, ECMO, extracorporeal membrane oxygenator, became more of a pressing issue. And we have now been able to get patients on ECMO in Greenwich Hospital by bringing the services down in a mobile unit from the Yale New Haven Health System via the ambulance or the helicopter. So we're actually providing the supportive care at the site almost emergently. We've never had to do that for a cardiac patient.
But this is Francine LaRusso. I have to comment on that because during the COVID era, that was absolutely, there were several patients that we had to transport, and we were very, very fortunate, and those patients actually were able to be discharged from the hospital. But it is a mechanism that we were able to insert cannula here and transport immediately. And it's a skill set that is quite unique.
Okay, so typically the expected emergency transfer time from Greenwich Hospital to Yale New Haven Hospital, can you provide me with averages with regards to both ambulance transfer as well as helicopter transfer?
That was in one of the documents. I don't think I have that. It was in one of the documents. I don't know if it was.
Well, depends what time of day.
Attorney Mitchell and Ms. Nagy, could we request that be filed as a late file document? Not sure we have that at our fingertips right now.
That'd be great. I'll defer to Attorney Mitchell to see if we can allow that as a late file, but I have no objection.
We can do it. We'll discuss all the late files at the end. Thanks, Han.
Okay, excellent. Thank you.
Okay, now I'm going to ask you a couple questions about the PCI quality measures that are currently being utilized at Greenwich Hospital for its primary PCI program. Can you talk a little bit about that and explain if there are additional measures or what additional measures that you take specific to elective PCI?
So Probably the starting point for quality assessment for the cath lab is this voluntary data registry called the NCDR. And that's sponsored through the American College of Cardiology, and it's a very robust data set. And they try to group your data, you submit your data, your outcomes, and try to group you with other hospitals of a similar size and what you perform. Then you can kind of benchmark yourself to other hospitals that are doing theoretically similar behaviors. And that data entry set actually has the ability to separate, unlike apparently the state of Connecticut couldn't separate primary angioplasty from other acute MIs. And that's why I think some of that data that was discussed earlier today all mixed together, they look like so many MIs. You can separate this in the data set so you know what's a STEMI, what's a PAMI, what's an ACS patient, what's a more stable elective patient. And the data set is much more robust than just looking at mortality. And obviously mortality is, in the end of the day, one of the most powerful and worrisome statistics. But really, when we're looking at our process, we're interested in appropriateness of care, doing it on the right patients, renal outcomes, bleeding outcomes, stroke outcomes, and all of that can be isolated and separated down on a case-by-case basis. And that data is available to us on a rolling quarter basis. So we review that every quarter. And fundamentally, it wouldn't change. We would obviously have more patients to put into the data set. And the data would be a little different because right now, all of our patients are primary patients. And now we'll kind of almost have two groups of patients, the primary and the elective. And that does get, teased out a little bit differently because like kidney dysfunction, which is actually the most common complication in cath lab-based procedures, that's very hard to measure in primary angioplasty because none of these patients have known kidney function at the time of the procedure. They're coming in emergently. Whereas elective angioplasty, all of those patients have a creatinine kidney test beforehand. So there are nuances and differences in the data set, but the acquisition and the inputting of the data would be more or less the same. In addition to that NCDR thing, as I alluded to earlier, we look at every angiogram. I know the physicians that are doing all these procedures. We talk about every case. And, sometimes that's as useful as an outcomes thing. What did you think of that angiogram? Should we have taken another picture of the right coronary artery? There's always room for improvement for all of us.
Yeah, so do you anticipate that based on the quality metrics, were the proposal to be approved, being changed, or the way that you offer these procedures, like being changed in terms of the quality metrics at all based off of the results of the PCI, of the elective PCI rather?
Can you just state the question? I'm not sure I got it.
Sure. So you were alluding to the fact that there'd be kind of two data sets, basically the primary data set that you have currently, and then going forward, you would also have an elective data set. Do you anticipate that, or will you be willing to look at the results of the elective PCI data set and change your quality metrics if necessary, or to address those metrics, your quality?
Absolutely, and I think it will actually make our quality data set better. It'll be more robust. And I actually think in the elective angioplasty population, a lot of those data points are more relevant. The primary angioplasty, a lot of what happens is a little bit out of our control. The horse is, quote, out of the barn. The elective angioplasty, we're kind of saying that this is an appropriate patient to do this is an appropriate time to do it, this is an appropriate location to do it. So we definitely have to look in the mirror and make sure we're doing it correctly and appropriately. So absolutely.
And Ms. Nagy, I mean, I would say that, you know, currently all our procedures are entered into the NCDR registry across the Heart and Vascular Center, including all elective as well as primary angioplasty. And so we would, as part of our leadership role, we would require that to happen. You know, if elective PCI was granted to Greenwich Hospital, because it would be consistent with the standards we apply in all our elective PCI programs.
Okay. So I'm going to shift a little bit and talk about the cost to the system, as well as the financial feasibility going forward. Given the current climate, will Yale New Haven Health Services experience operating losses in fiscal year 2020 due to COVID-19? And if so, can you project how much?
This is Norm Roth. Yale New Haven Health System will experience operating losses in fiscal 2020 as a result of the impact of COVID-19. And that amount, if you exclude the federal stimulus money, is approximately $400 million. With the stimulus money added in, right now it is looking like the anticipated loss will be between 40 and $50 million. And as we look forward to fiscal 21, we are seeing a strong recovery of patients, both inpatients and outpatients, in all of the healthcare facilities of Yale New Haven Health. And in fiscal 21, we are expecting a break even to perhaps up to 3/4 or 1% positive operating margin.
Assuming no.
Okay. And then would you be able to kind of answer that question again in terms of Greenwich Hospital, so I can repeat the question? Will Greenwich Hospital experience operating losses in fiscal year 2020 due to COVID-19? And if you would be able to project an amount?
Yes, so COVID-19 hit Greenwich Hospital extremely hard and very early. Our first patient was on March 14th, 2019. We peaked in mid-April at 2020, March 14th, 2020. And then in April, we peaked at 126 inpatients and 26 ICU patients, testing the very limits of this organization. Naturally, when we knew that that volume was coming, we discontinued outpatient services, elective services, created additional bed capacity, and Diane Kelly worked with our staff, got us to a bed capacity approved by the Department of Public Health up to 284 beds. We were able to segregate non-COVID patients from COVID patients. And throughout the entire COVID-19 period, we have now seen nearly 740 patients at Greenwich Hospital, a very significant number of patients. So in fiscal 2020, without federal stimulus dollars, Greenwich Hospital will lose approximately $35 million. But when we are able to add in the stimulus funds for lost revenue provided by the federal government and FEMA, we are actually forecasting a slight operating gain at this organization of approximately $5 million. Looking ahead at fiscal 21's operating budget, and I will make the clarifying statement, assuming no major resurgence of COVID-19 at the levels that we saw in March, April, and May, and into June, we are forecasting that Greenwich Hospital will end the year with a favorable operating margin of about $9 million for the year for fiscal 21.
Okay, great, thank you. So do you anticipate the projected losses by the system will affect this transaction? And if so, how?
We don't anticipate any impact on this proposal, and there's no impact on Greenwich Hospital. In fact, you know, from a healthcare cost perspective, we think it is actually favorable for both the state and the patients because all the services that are required for elective PCI already exist at Greenwich Hospital. All the supplies, staff, physicians are all here. So rather than incurring additional expense of ambulance transportation, sometimes occasionally repeat examinations and second and procedures, it all could be done here. So from a healthcare cost perspective, we believe this would actually be an improvement in overall healthcare cost.
And can you speak to the losses to the system as well, if that will have an impact? You spoke about the hospital specifically.
The health system totally supports this. They are co-applicants. This is Greenwich Hospital and Yale New Haven Health System. And the Yale New Haven Health System is going to have the same experience going to 21 as we have today. And volumes at Yale New Haven and Bridgeport hospitals are such that they are frequently in a surge alert, meaning that there are so many inpatients in the facility that it creates significant delays in the emergency department. In fact, prior to COVID, Yale New Haven was experiencing 80 or so, sometimes even higher, patients waiting for inpatient beds. So actually, from a health system perspective, performing more of the elective PCIs here would relieve some of the burden on the busiest angiography program in the state of Connecticut at Yale New Haven Hospital.
Okay, great, thank you. So I'm gonna hand it off to my colleague, Brian Carney, to finish up the questions.
Thank you, thanks, Hannah. Good afternoon, everyone. I have several questions for the intervener, Stanford Health.
Good afternoon.
Good afternoon, gentlemen. All right. First question is, in your words, if elective PCI is approved at Greenwich Hospital, what do you think would be the impact on Stanford Hospital's cardiac program?
You want to take the question from a clinical standpoint? Are you, can we clarify your question from impact, meaning, can you be a little more specific about what you're talking about from an impact perspective?
Sure, I'd say, as you're saying, the clinical piece of it, the financial impact of it for the hospital, clinical impact of it for the program, the volume impact for the program.
Sure. So I can address again some of the questions relative to more the business side, and I'll let my colleague Dr. Martin talk a little bit more about it from a clinical side. As I think was asked, the questions were asked during the cross-examination about whether we've done any volume projections, have we done any cost financial implications. We have not done that, and that's truly not the basis of our argument here. We do believe there's going to be an adverse impact across all providers throughout the geographic area when another program would be implemented, to the level of specificity that may entail. there's a lot of speculation that would be caused with that, but we do think it would have some impact to us. And I think beyond that part is, and as I mentioned before, there is a national decline happening across the country. And that is something that would cause potential additional degradation to overall case volumes when we're ensuring that we meet the gold standards. If you want to talk anything more from a clinical standpoint.
Clinically, I think if this program went through, we wouldn't see any dramatic change. I think our volume is such that we're not in danger of closing. We're not in danger of becoming a low quality program. I think day to day, my job wouldn't change. What I do worry about is, aside from working at Stanford Hospital, I have patients and colleagues and friends who live in Greenwich, and I would just hope for their sakes that we continue to uphold the gold standards and provide care as best available as guided by our consensus guidelines.
Okay, does Stanford Hospital have available capacity to increase the number of PCI procedures performed? And if yes, how many additional PCI procedures could you do?
Sure, we certainly have capacity. I would say we could nearly double our capacity, nearly double the number of procedures we're doing now, and still provide quality care. We're reasonably busy, but we have 3 cath labs that are running all day, and there are definitely openings. I read in some of the testimony from the applicant about patients having to wait days to get procedures. That certainly would not be the case here. When we do get transfers from Greenwich or from Norwalk, those procedures, we're typically waiting for the patient to get here to take them for the procedure immediately.
Okay, can either of you 3 gentlemen name the primary service area towns served by Stanford off the top of your head?
Sure, I can address that question for you. So we look at Stanford and Darien as our immediate primary service area, and our additional air service area. And pardon me because I am still fairly new to the geography, that if I don't capture all the names, we will get to you in follow-up, but would include Greenwich, New Canaan, Wilton, Norwalk, and Westport, but let me, to give you clarity and factual, let's give you that information in a follow-up if you're okay with that.
Sure, but you're saying basically just the primary service area is 2 towns, Stanford and Darien?
We consider that our immediate service area, our immediate primary service area.
Okay, our definition is usually like top 85% of discharges.
Yeah, I don't have that information readily available to my knowledge.
Okay. Couple other things I'm interested in knowing, which I'm sure you're not going to have that at the top of your heads either. We can ask them as late files, but I'll just mention them. Would be for you to provide us with the annual historical volumes for primary and elective PCI at Stanford Hospital for the past 3 fiscal years. Also providing us the yearly totals by patient town of residence for primary and elective PCI. So we're going to ask you for that. And lastly, we'd like to have a sort of an idea of where you think the program's going. So we'd like you to provide us with the annual projected volumes for primary elective PCI anticipated over the next 3 years, and what you'd anticipate if this proposal goes through, so with or without the proposal, or if not. Sort of to kind of quantify, that impact on volume.
Understood. Be happy to provide that.
All right. As of now, that's all the questions I have. Michaela?
Attorney Mitchell, with respect to the late files, would like an opportunity to respond to the documentation, if that's okay?
Yeah, I'll give you a brief amount of time to respond after we receive them. And in addition to that, we had a couple of requests for late file for your clients as well. So we, it probably will make better sense for me to issue it in a written order so everybody has everything. But we were looking for from you updated financials from 2019 to 2022. We wanted to get the estimated distance between Greenwich Hospital and White Plains. And then we also wanted to get, I think Hannah was asking for the average time for an emergency transfer from Greenwich to both Bridgeport and Yale New Haven hospitals, either, I guess, by ambulance. I'm sorry, I think I said ambulance, but by ambulance and by helicopter. So those are the things that we would be looking for. I know we've only verbally talked about them. I'll probably, not probably, I will issue an order tomorrow requesting everything in writing so that you have that handy so you don't have to remember everything now. But since we've gone over them verbally, I wanted to ask how much time you need to produce the documents that we've discussed. I'll start with the applicants.
Was the question how long it would take to respond to the late files?
Yeah.
I would request at least a week and a half through the end of next week to gather the updated financials. That's probably the most time consuming of each of these tasks. So if we're looking at a calendar,
The 9th is a week from Friday.
October 9th would be Friday, a week from Friday.
can we set the 9th as a date?
Okay. Are you amenable to that, Attorney Monahan, for the production of the information that we need from your clients?
Yes.
Okay. And then I will give a little bit of additional time for a response from the applicants to the interveners' information that they provide, their additional evidence. I don't want this to drag on too long. I'm thinking, I don't know, do you need 3 full business days?
I think that's reasonable. So 3 full business days. The Monday, Tuesday, Wednesday following the 9th.
COB the 14th.
Yeah, just a
Good
question.
dates, I can't help it.
So 12th is Columbus Day. Are y'all working on the 12th?
Oh, that's a good point.
It's not a holiday.
Not a holiday for us.
It's not a holiday at Yale New Haven.
Not a holiday.
Not a holiday. All right.
That's reasonable.
So you want to say close of business on the 14th?
Agreed.
Okay. All right, I will issue an order on that. I don't know if there's anybody else from the public that is on listening. If you are, I'm going to ask if you unmute yourself and just kind of let us know that you're there. If you want to speak. All right, so hearing nothing, I'm going to go ahead and adjourn the hearing. We'll issue the order for the additional documentation tomorrow with the agreed upon dates, and it'll have the specificity that you need to make sure that you produce everything that we're asking for. In addition to that, I just want to thank everybody for convening virtually. It is not easy for everybody to sit in the same room for as long as you did. especially aren't under the current circumstances. So I just really appreciate it. I appreciate all of the people who are participating from the public, just giving us your time and letting us know what you think about this application. And if you have any questions or concerns, please feel free to reach out to us. Attorneys know to copy one another on correspondence. But other than that, we're going to go ahead and adjourn the hearing for today. The record as it stands is going to remain open until October 9th for any additional comments or submissions. So we're all set at this point. Everybody okay? Everybody all set?
Yes.
Yes.
Thank you
Thank
very
you.
much.
Appreciate your time.
Everybody, thank you.
Thank you. Have a good evening.
Brian, thank you, Leslie. All right.
Thank you.
So on Monday, I'm a public
Oh.